starting point. Again, if the patient has oscillopsia, we're going to focus on gaze stabilization. If they have problem with visual vestibular integration, then we're going to do habituation, optokinetics, virtual reality, visual conflict. And if they have vestibular recruitment, we will focus more on habituation. If it is a balance dysfunction, dynamic surfaces, multiplane stimulation, perturbations, anything that challenges the patient's center of gravity over a dynamic base of support. And the benefits for many of these patients is it may be the only treatment. Pharmacologically, they're not candidates. Surgically, they're not candidates. And for the majority of patients, it will bring them back to normal or very close to normal functioning. Now, at the Institute, and for almost 30 years, what I have developed is a hybrid approach so that we don't waste time with our patients. We make sure also, based on the science, that we're always adding a good bit of cognition. Because what we know from research with PET scans is that VRT actually changes the biochemistry of the brain. So the good thing about vestibular rehab is it doesn't take a lot of expensive equipment. If you don't have the budget, you can use everyday simple things. If you have the budget, you can use technology all the way to vestibular therapy using virtual reality. But there's no reason not to do therapy because you don't have advanced technology. So let me show you in our last few slides here together what something might look like. This is a good example of a hybrid therapy. The patient is going to be turning her head, so we have some habituation. The patient is going to be reading while she's moving her head, so we have gaze stabilization. We also have balance stability because she's walking while she's doing this. Now, if you notice, she's wearing the shoes she would normally wear. When we're doing therapy, we're going to have the patient wear the shoes that they would normally wear. So the patient now is walking and reading. Now, we can make this more difficult by changing the font size. We can also make it more difficult by changing the speed at which she moves her head by using a metronome. But now let's make it even a little bit more difficult and give her a dynamic surface. So gait with head movement. We're managing oscillopsia, we're managing vestibular recruitment, and we're managing imbalance on dynamic surfaces. And cognition is incorporated in everything we're doing. If you notice, Jo has a gait belt on her to ensure the patient's safety at all times. Now, let me just take a moment to talk about cognition. This is one way to use cognition. It could be words, it could be numbers, it could be symbols. So if you have somebody that, for example, maybe can't read, this is wonderful. So we can say to them, how many blue triangles are there? How many orange circles are there? There aren't any orange circles. How many blue squares are there? How many blue triangles are there? Okay, read the bottom row and tell me the color of every item. Green, red, blue, green, red, yellow, yellow. Okay, now across the top, tell me the symbol. Oh, square, diamond, triangle, diamond, circle, circle, triangle. You see? So we can add cognition in this along the way. Outcomes, outcomes, outcomes. If you didn't measure it, it didn't happen. So what we want to do is we want to extinguish the oscillopsia by having the patient be able to read smaller and smaller fonts in shorter time intervals with faster and faster head movement. With habituation, what do we want to do? We want to extinguish the severity of the symptom with the movement, and we want to decrease and extinguish the length of the prolongation of the symptom after the patient has stopped moving. So, in summary, we're going to put into effect those tools that will best, number one, reveal what the patient's functional deficiencies are, what are their functional impairments, and then we're going to make sure that we use the right diagnosis-based strategies of therapy, and then we're going to make sure that we have been successful by using outcome measures. Remember, the brain can't fix what the brain can't see. The therapy protocols must be interesting, new, and provocative. No movement, no improvement. Concentration and attention does make it better. If the patient is compensated, don't try to fix it. Go to the area where the problem persists. And again, if you didn't measure it, it didn't happen. So, my friends, I want to thank you for spending this time with me to review the multidisciplinary approach to the management of adult patients. Obviously, this is only 30 or 35 minutes. Normally, we would teach this over a period of 2 and 3 days. So if you'd like more information, it's free, it's open access. Go to dizzy.com. You can download all of the research, the articles, the textbook chapters. And if you go to the Dr. Gans blogs, you can watch a lot of the blogs as well. So until we see you again soon, whether it's here or somewhere else, thank you. And so Laura, thank you again for being our host.
That's the least we can do. We're getting a lot of thank yous, and I'm going to ask if we have any questions. We'll wait to see if we have a couple of minutes to see if we have any questions.
Sure.
Personally, I found that posturography, dynamic posturography, not with virtual reality, let me be very honest, the regular one. One of the things that my patient really love is the green and red changes. And I feel like it brings even psychological relaxation when they see their scores, although there is a habituation definitely involved, but when they see their scores becoming better, that gives them a relaxed, they're relaxed when they see their scores. Do you have anything similar, or do you have any, do you show your patients on a graph, for example, their improvement, or do you only rely on personal observation for the patient, I mean?
No, because so even if it's personal observation, we're scoring. Can you see the screen again?
Mm-hmm.
Yeah, we're always showing scores.
Perfect. And you share this with the patients.
These might be behavioral scores.
Mm-hmm.
So there's 2 types of scores, objective and subjective.
Mm-hmm.
But we can measure anything.
That's
so
great.
if we come over here, mm-hmm. Obviously, when we're using technology, we're always showing them over time what their scores are. But for those facilities that don't have technology, mm-hmm. Create an Excel spreadsheet.
Okay.
Create an Excel spreadsheet, mm-hmm. and you could show the patients this kind of performance.
Great. Thank
This
you.
is not, this isn't computer generated.
Yes, that's
This can be
example.
just patient. So let's say you do a dynamic visual acuity test,
Mhm.
right? And the patient on day one can only see 30% of the 18 fonts, but on week 3 or week 4, they get 100%. So you simply put it into a graphic representation using an Excel spreadsheet.
Got it. Thank you again for the lecture.